You crash in the afternoon so predictably you could set a clock by it. You wake at 3 a.m. with your mind already running. You need caffeine to feel human before 10 a.m., and then cannot wind down at night despite being exhausted. Salt cravings that feel specific rather than casual. Not a preference, a pull, a dizziness when you stand too quickly that takes a moment to resolve. And underneath all of it, a tiredness that is present even on the days when nothing happened. You have probably read about adrenal fatigue. You have probably also been told by a doctor that it is not a real diagnosis, which is partially true and almost entirely unhelpful. Adrenal fatigue as a clinical label is not accepted by mainstream endocrinology. But the physiological process it attempts to describe, a dysregulation of the HPA axis, the hypothalamic pituitary adrenal system that governs the body's cortisol response, is real, measurable, and increasingly documented in the research literature under different terminology: HPA axis dysfunction, hypocortisolism, stress system blunting. The argument is about the name. The symptoms are in the body regardless of what the name is. And the one symptom most consistently missed, the one that is most specific, most measurable, and most likely to lead to a correct investigation, is orthostatic hypotension. A drop in blood pressure when moving from lying or sitting to standing. A dizziness, a graying of vision, a momentary unsteadiness that passes in seconds, and that most people have been told is nothing. It is not nothing. To understand why this symptom matters, you need to understand what cortisol actually does, beyond the stress response most people know it for. Cortisol is not just a stress hormone. It is a regulatory hormone that touches almost every system in the body. Among its functions is the maintenance of vascular tone, the baseline tension in blood vessel walls that keeps blood pressure stable when the body changes position. Cortisol works alongside aldosterone, the adrenal hormone primarily responsible for sodium retention, to ensure that when you stand up, the blood that would otherwise pool in the lower body is pushed upward to maintain perfusion of the brain. When the adrenal system is dysregulated, when cortisol output is blunted, or the diurnal rhythm that normally produces a morning cortisol spike has flattened, vascular tone is inadequately supported. The blood vessels do not respond with sufficient speed and force when the person stands. Blood pools in the legs. Blood pressure drops momentarily. The brain receives less blood than it needs for 2 to 5 seconds. The person experiences this as dizziness, lightheadedness, a brief graying or narrowing of vision, or a sense of needing to grab something to stabilize. And then it passes, because other compensatory mechanisms kick in. This is orthostatic hypotension, clinically defined as a drop of 20 millimeters mercury or more in systolic blood pressure, or 10 millimeters mercury or more in diastolic blood pressure, within 3 minutes of standing. And in its milder, symptomatic but below threshold form, sometimes called orthostatic intolerance, it is one of the most consistent physical findings in people with HPA axis dysfunction. The reason it gets missed is partly measurement and partly assumption. Blood pressure in a clinical setting is almost always measured seated. The patient sits, the cuff goes on, the reading is taken. If that reading is normal, which it typically is in HPA dysfunction, because the system is compensating adequately at rest, the blood pressure is recorded as fine and no further investigation occurs. The symptom the patient reports, standing up and feeling momentarily dizzy, is attributed to dehydration, getting up too fast, or dismissed entirely as benign positional change that everyone experiences. The measurement that would reveal the problem, blood pressure taken lying down, then immediately on standing, then again at 1, 2, and 3 minutes, is not performed. The NASA lean test, which replicates this protocol in a standardized way, is not part of routine clinical assessment. The 10-minute standing test, used in research settings to assess orthostatic response in patients with suspected dysautonomia and adrenal insufficiency, is almost never done outside specialist centers. So the symptom exists, the patient reports it, the measurement that would objectify it is not taken, and the conversation moves on. The cortisol rhythm is where the investigation becomes more revealing, and where the standard single-point blood test fails in exactly the same way the TSH test fails for thyroid. Cortisol is not a stable hormone. It follows a diurnal curve that is as predictable and physiologically essential as the sleep-wake cycle it governs. It peaks sharply in the 30 to 45 minutes after waking. This is the cortisol awakening response, a deliberate surge that prepares the body for the demands of the day. It then declines through the morning and afternoon, reaching its lowest point in the late evening to enable sleep onset. In HPA axis dysfunction, this curve is disrupted. The morning peak is blunted or delayed, which is why mornings feel catastrophically difficult, why functioning before caffeine is genuinely impaired rather than merely habitual, and why the requirement for exogenous stimulation to reach a functional state is so consistent. The afternoon trough arrives early and sharply, producing the predictable 2 p.m. to 4 p.m. energy collapse that is characteristic enough to be diagnostic on its own. And the evening low fails to occur adequately, meaning cortisol remains relatively elevated at night when it should be minimal, contributing directly to the 3 a.m. waking with an activated mind, the inability to wind down despite physical exhaustion, and the non-restorative sleep that accumulates the fatigue further. A single morning serum cortisol, the standard test, cannot map this curve. It takes one data point at one moment and compares it to a reference range derived from population means. Unless the morning peak is significantly low enough to suggest frank adrenal insufficiency, the result will be reported as normal, because it is normal at that moment. The problem is not the value at 8 a.m. It is the shape of the curve across the day. A 4-point salivary cortisol test, taken on waking, at noon, in the afternoon, and at night, maps the diurnal rhythm directly. It reveals a blunted morning peak, an early afternoon crash, an elevated evening value that should be near baseline. This is the test that makes the pattern visible. It is available, inexpensive, and almost never ordered in primary care. The salt craving deserves its own explanation, because it is not a preference or a dietary habit. It is a physiological drive produced by a specific hormonal state. Aldosterone, the adrenal hormone responsible for sodium retention, works in concert with cortisol. When adrenal output is dysregulated, and both cortisol and aldosterone are running below optimal, sodium is retained less efficiently. The kidneys excrete more sodium than they should. Blood volume falls slightly. The body responds with a specific craving for salt, not sweet, not fatty, specifically salt, as a compensatory drive to replenish what is being lost. This salt craving is one of the cardinal symptoms of Addison's disease, frank primary adrenal insufficiency, where it is taken seriously as a diagnostic feature. In the subclinical functional version of adrenal dysregulation, it is reported consistently by patients and dismissed consistently by clinicians because the serum sodium is typically within normal range, which it is because the craving is working. The person is consuming enough sodium to keep the blood level normal while the underlying regulatory deficit continues. When the salt craving coexists with orthostatic dizziness, morning fatigue, afternoon crashes, and disturbed sleep, the pattern is not coincidental. It is a coherent physiological portrait of a system that is not regulating sodium, blood pressure, or cortisol across the day with the efficiency it needs. Addison's disease, true primary adrenal insufficiency, where the adrenal glands themselves are damaged, most commonly by autoimmune destruction, sits at the severe end of the spectrum and carries the same symptom cluster in amplified form. Profound fatigue, orthostatic hypotension severe enough to cause fainting, hyperpigmentation of the skin, particularly in the creases of the palms, the gums, and sun-exposed areas, a darkening caused by elevated ACTH-stimulating melanocytes as the pituitary attempts to drive the failing glands harder, weight loss, nausea, and a salt craving so compelling it can override other appetite entirely. Addison's is rare, affecting approximately 1 in 10,000 people, but it is underdiagnosed in its early phases precisely because the symptoms accumulate slowly enough to be normalized, and because the standard blood tests, a morning serum cortisol and an ACTH stimulation test, are not performed until clinical suspicion is already high. An early morning cortisol below